European School of Oncology, the e-session will start soon. Thank you for your patience. Today's e-session will start at 6:15 p.m. Thanks for waiting. European School of Oncology, the e-session will start soon. Thank you for your patience.
Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to the e-session 586. Today's session is CAR T-cell therapies in pediatric solid cancers. Please note that this activity is CME accredited. At the end of the presentation, go back to the ESO website to complete the evaluation form and the CME multiple choice test. Mastermind competitors will be prompted to start the quiz after having completed the evaluation. As a reminder, during the live session, all participants can ask questions live at any time by simply pressing on the relevant button at the bottom of the page. Questions will be received by Dr. Paula Perez Albert, of the Young SIOPE Educational Group member, Sant Joan de Déu Hospital, Barcelona, Spain, and Dr. Roelof Vanovic, of the Prinses Maxima Center for Pediatric Oncology, Utrecht, the Netherlands, who will discuss them with Professor Franco Locatelli, of the URCS, Ospedale Pediatrico Bambino Gesù, Rome, Italy. Here is an extract of the policy which is published on our website in full. I will now hand over to Dr. Perez. Doctor, your line is now open.
So welcome everybody. I am Dr. Paula Perez. I'm a Young SIOP member. And with Dr. Elwick, we are both happy to present the first Young SIOP and ISO session. And I would like to acknowledge the speakers for today's session, Dr. Franco Locatelli. Dr. Locatelli is a well-renowned expert in childhood malignancies with a special expertise in cellular therapies from bone marrow transplant and CAR T-cell therapy. He's the director of pediatric hematology and oncology department at the Ospedale Bambino Gesù in Rome, as well as a professor of pediatrics in La Sapienza University and the president of the Italian Superior Health Council. So thank you very much for accepting our invitation and for sharing your knowledge and your time with the young oncologist community. And now I will give you the word, Dr. Locatelli.
Many thanks for the kind introduction, and it's a great pleasure to be here today to discuss with you the issue of the potential role of CAR T-cell therapy in solid tumor. It's really a privilege for me to have the opportunity to discuss with all of you these important translational research approach. These are my disclosures. And let me start this presentation briefly summarizing the main advantages of immunotherapy. Indeed, activated immune cells can recognize and target remote antigens present on cancer cells, and the stimulated immune system will not necessarily target only cells that rapidly divide. It's also important to know that the immunotherapy is associated with fewer or less devastating side effects than traditional therapies. And the memory cells that can be generated through the approaches of immunotherapy may prevent cancer from returning after the initial treatment. And there are now available several lines of immunotherapy, including the checkpoint inhibitors, the antigen-specific antibodies, in particular the bispecific T-cell engager, oncolytic viruses, and cancer vaccine. However, today I will focus my presentation on gene-modified T cells, namely the CAR T cells, which are autologous T lymphocytes genetically modified to be redirected against the specific target antigen. And talking a little bit more about the differential toxicity between chemotherapy and CAR T cells. In the short term, the latter can induce the so-called called cytokine release syndrome, usually occurring between day +1 and +10. And the severity of this complication is strictly dependent on the tumor burden at time of treatment. There are other toxicity that can occur in the patients, including the neurotoxicity and the cytopenia, which sometimes may be prolonged over time and associated with features of hemophagocytic lymphohistiocytosis. And all of us are aware that there are many trials open worldwide on the use of CAR T-cell therapy, in particular on hematological malignancies. Indeed, among the more than 1,000 clinical trials in the world, only 53 focus on patients with solid tumor. And to the best of my knowledge, in Europe, there are only 3 trials specifically enrolling patients with solid neoplasia. If you look at the situation on the pediatric population and you evaluate this cartoon, you may immediately realize that the number of active clinical trials is even lower than that of in the adult population. And they mainly involve neuroblastoma, sarcoma, brain tumors has the main neoplasia possibly treated with this approach. And also the number of targets that have been utilized for the CAR T-cell therapy approach is limited. Indeed, again, you immediately realize that only 6 potential targets have been employed to develop CAR T-cell approaches in solid tumors. One of the reasons why there is a limited number of clinical trial enrolling patients with solid neoplasia is related to the fact that there are several obstacles that have to be overcome for rendering the approach really successful. And these obstacles mainly refer to the identification of suitable target antigens, which are either selectively or preferentially expressed by tumor cell. We have also to overcome the obstacle of the penetration of CAR T cells in the tumor mass, and it's important to emphasize the concept that the tumor microenvironment is oriented towards a direction potentially depotentiating the activity of immune approaches, not to talk to the need of T lymphocytes to survive into the hypoxic tumor environment. And please remember that you can ask questions on my presentation and send comments at any time. In particular, I'd like to share with you our experience on neuroblastoma, because we have activated in Italy the first clinical trial on pediatric patients with neuroblastoma that represent the most common malignant extracranial solid tumor, and the metastatic presentation in this disease is rather frequent, being observed in more than 50% of patients. And when the patient have a metastatic neuroblastoma, or the tumor elements carry poor risk molecular features, including the amplification of MCAN, the prognosis, as you can observe in the lower part of the cartoon, remains really poor. And more importantly, we have not been able to improve the outcome of these patients over time, despite the multimodal approach that have been implemented, combining chemotherapy, surgery, autologous transplantation, radiotherapy, and immunotherapy with the monoclonal antibody. For this reason, and also considering the demonstration of activity of immunotherapy with antibody targeting GD2, which is the cell-ganglioside expressed on the surface of the tumor element. It's not surprising that the CAR T cells were considered a potential strategy for trying to treat this particular neoplasia. More in detail, 5 different papers have been published on CAR T cell targeting GD2, including construct of first, second, or third generation, namely without, with one, or with 2 costimulatory domains. And all these studies demonstrated that the CAR T cells can expand over time. They may induce some objective clinical response, and more importantly, the safety profile of the approach was confirmed in all the trials. So we decided to invest on neuroblastoma, designing a 3rd generation CAR targeting GD2, in which the costimulatory domain that we included are CD28 and 4-1BB. We also decided to include into the CAR construct the inducible Cas9, which is a safety switch able to lead to the apoptosis of CAR T cells in case of undue toxicity, which cannot be controlled by conventional pharmacological therapies. The choice of this combination of costimulatory domain is the result of an extensive preclinical trial in which we demonstrated that combining CD28 and 4-1BB resulted into the better efficacy of the CAR T cells, and in particular into the best survival of the animals infused with neuroblastoma cell lines and then with the CAR T cells. The clinical trial that we design includes patients with high-risk neuroblastoma which failed frontline therapy during the phase 1 and 2 portion of the study, while in the phase 2 portion, we also considered that to include children with high-risk neuroblastoma and a considerable risk of relapse. We designed a classical phase 1 and 2 clinical trial in which, during the phase 1 portion of the study, we considered an escalating, de-escalating design, starting at the dose level 3, namely 3 million of CAR T cells per kilogram recipient body weight, with the possibility of increasing to 6 and 10 million in case of a good tolerability, or decreasing to 2 and 1 million in case of a dose-limiting toxicity. All patients were given CAR T cells after a lymphodepleting treatment based on the combination of cyclophosphamide and fludarabine. If you look at this cartoon, you immediately realize that we didn't observe any dose-limiting toxicity. So we were able to demonstrate that the maximum tolerated dose or recommended dose is 10 million per kg. Moreover, looking in detail at this table, you can appreciate that all patients had originally a diagnosis of metastatic neuroblastoma, in many cases associated with amplification of McCann, and all patients but one fail several lines of treatment. Only one patient treated in the phase 2 portion of the trial didn't have evidence of the disease, while the disease status at time of infusion clearly demonstrated that all patients were in relapse or had resistant disease, and all children with sizable tumor burden. After the infusion of the CAR T cells, the elements expand over time, reaching a peak around 2 weeks after the CAR T cell infusion, which is associated with the greatest levels of CRP and ferritin. And the expansion of the CAR T cells involve both the CD8 and the CD4 subset of elements. Moreover, and very importantly, the GD2 CAR T cells are able to migrate into several different sites, including the bone marrow, the cerebrospinal fluid, and also we found in a couple of patients the CAR T cells in the peritoneal effusion because we perform a parasynthesis in these children. The expansion of the GD2 CAR T cells correlated with the cytokine profile and with the occurrence of cytokine release syndrome. Indeed, you can observe that the cytokine peak was higher in patients developing CRS of grade 2 to 4. And the expansion of the CAR T cells is associated with the production of the non-cytokine involved in CAR T cell therapy, namely interleukin 10, IL-6, and interferon gamma. Considering that we had the opportunity to take advantage of the presence of the inducible caspase-9 switch, we activated the suicide gene in 2 patients who developed toxicity which was not manageable through the use of corticosteroids or tocilizumab. And you can appreciate that the infusion of the dimerizing agent able to activate the inducible caspase-9 was associated with a rapid disappearance of CAR T cells in peripheral blood, with a subsequent regrowth of the CAR T cells not associated with any flare of the toxicity. Again, let me remind that you can ask questions and send comments at any time during my presentation. In terms of clinical efficacy, many patients responded, and in particular, the overall response rate and the 22 patients that we recruited in the phase 1 and in the initial part of the phase 2 portion of the study is 80%. And more than 1/3 of patients obtain a complete remission or maintain non-evidence of the disease. Also looking at the probability of both overall and event-free survival, you can appreciate that around 50% of patients are alive at 2 years when the expected probability of being alive in this very advanced population of patients with conventional therapy is in the order of 10%. And the results in terms of both overall and event-free survival are even better for those patients who had unlimited tumor burden at time of CAR T cell infusion. Let me also share with you some images, in particular this MI scintigraphy in a child with metastatic lesions. And you can appreciate that already at week 6 after cortisone infusion, there was a complete clearance of the metastatic lesions as demonstrated by the MI scintigraphy. And considering that GD2 can be expressed also on the surface of tumor elements in Ewing sarcoma and osteosarcoma, we decided to amend the protocol to treat also patients with these bone disorders, malignant disorders. And you can appreciate that after the cortisone infusion, there was an almost complete clearance of the disseminated lesion in the child with Ewing sarcoma, whereas in the patient with osteosarcoma, the cortisone infusion was associated with a complete disappearance of the lung metastasis as well as of the tumor lesions involving the costal bones. But talking about the use of GD2 targeting CAR T cells offers me the opportunity to mention that also rhabdomyosarcoma may express GD2, and indeed we are conducting an experimental preclinical work demonstrating that the infusion of GD2 targeting CAR T cells is able to clear the tumor cells in the animals that were initially treated with the infusion of the rhabdomyosarcoma cell lines, then followed by the infusion of the GD2 targeting CAR T cells. There is another important potential application of GD2 targeting CAR T cells, and namely brain tumors. And we developed an experimental model in which we infuse glioblastoma cells orthotopically into the skull of the mice. And 3 days later, we infuse intravenously the CAR-GD2 T cells that were able to migrate into the brain of the animal and to kill the tumor elements. And indeed, if you look at the bioluminescence cartoon, you can nicely appreciate that the infusion of GD2 targeting CAR T cells was able to completely rescue the animal from the infusion of these GD2 glioblastoma cell lines. Again, a reminder for asking to raise question if you have concerning my presentation. So these experimental data are absolutely online with a manuscript that was published some years ago by Crystal McCall group, and the investigators demonstrated a potent anti-tumor efficacy of GD2 targeting CAR T cells in an experimental model of H3K27 mutated diffuse midline glioma. So there is certainly the future opportunity to implement the GD2 CAR T cell trial also in patients with brain tumors. And talking about brain tumors, let me touch also the issue of another potential target, namely CD276, or if you prefer, B7H3, because B7H3 is expressed on the cell surface of many malignant cells of brain tumors. And indeed, there is a clear correlation between the histological aggressiveness of several tumors and the expression of the B7H3. And in a high expression of B7H3 depicted in the red curve is associated with a poorer survival in patients with either glioma or ependymoma. And looking at the expression of B7H3, you can appreciate that the highest expression is found in ATRT, the typical teratoid rhabdoid tumors. And for this reason, several groups, including my own group, decided to invest on the generation of B7H3 targeting CAR T cells for this rare but very aggressive tumor associated with a dismal prognosis. And you can appreciate that in comparison to CAR T cell targeting CD19, those directed against B7H3 were able to obtain a complete control of ATRT. And as I mentioned before, we also decided to invest on this type of tumor. And for this reason, we have generated a CAR construct targeting B7H3. And again, also our data demonstrate the efficacy of the approach in rescuing the expansion of tumor elements in the animal model that we have developed. Let me spend the last 3 slides commenting about another option for treating with CAR T cell high-grade glioma that we know very well are associated with a very poor prognosis in patients. In particular, I am alluding to the possibility of treating glioblastoma with chimeric antigen receptor T cell targeting different antigens, namely the alpha-2 receptor of interleukin-13. And this seminal paper that was published around 5 years ago in the New England Journal of Medicine, the investigators demonstrated that the infusion of CAR T cells targeting the receptor alpha-2 of interleukin-3 were able, once injected into the resected tumor cavity, to obtain a clearance of the tumor lesions. But once the patient relapsed, the investigator decided to move to the intraventricular infusion. And you can appreciate again in this cartoon that after the intraventricular infusion of the CAR T cells, there was a very nice regression of the tumor lesions in the brain, as well as a clearance of a metastatic lesion occurring in the spinal cord. So also, this antigen can represent an option for developing effective CAR T cell therapy in CNS neoplasia. And finally, talking again about the efficacy of CAR T cells in sarcoma, it's important to mention the possibility of developing CAR construct targeting the epidermal growth receptor 2. And in this paper published some years ago in the Journal of Clinical Oncology, you can appreciate that in some patients, the infusion of HER2 targeting cortisol was associated with a nice reduction of the tumor lesion. So in conclusion, GD2 CAR T-cell are associated with a good tolerability profile, which can be further increased by the use of the inducible Cas9. Once infused, the cortisol expand, induce immune activation, and have a wide biodistribution documenting long-term persistence. These GD2-specific T cells have a strong anti-tumor activity that in a proportion of patients is maintained over time. A low disease burden at time of cortisol infusion is associated with better prognosis, and the other neoplasia, including CNS tumor, might benefit from GD2-specific corticells. And finally, several groups are now working to try to exploit cortisol targeting different antigens, including B7H3, HER2, and the receptor alpha-2 of interleukin 13. And I am pretty sure that in the future we will see additional data supporting the investment on CAR T cells in solid neoplasia for replicating the outstanding results that have been obtained in the B-cell lymphoproliferative disorders. Finally, let me thank all the people of my group who work in the program. A special mention to Dr. Quintarelli, Dr. Del Buffalo, Dr. De Angelis, Dr. Velarde, and Maria Vinci for the extensive preclinical work. Thank you.
Thank you very much. It's been an incredibly interesting session. I would like to ask you, I was wondering if CAR T cell, in your experience in neuroblastoma, if it persists, the CAR T cell, and how long the response persists during time.
So thank you very much for asking me this question, which allows me to further elaborate on this issue. As you notice, the probability of a 2-year event-free survival is approaching 30%, which is, in my personal view, a good result considering how advanced was the population of patients we treated. And in terms of persistence of CAR T cells, we have been able to document the detection of CAR T cells in patient peripheral blood up to 1 year after the infusion of these genetically modified T cells. I didn't mention during my talk, but it's the right opportunity to address also this issue, that the expansion of the CAR T cells is directly correlated with the presence of the myeloid-derived suppressor cell. In particular, the higher the percentage and absolute number of myeloid-derived suppressor cell, the lower the CAR T cell expansion and persistence over time.
Thank you very much. And I have another question. Because when we use anti-GD2 immunotherapy, we see a lot of side effects that are supposed to be on target because of the GD2, like pain, low blood pressure. So did patients have this? So I understand that they have the cytokine release syndrome, but do they have this kind of symptoms during time?
So thank you so much again for asking this important question. The CRS mainly occur in the first 2 to 3 weeks after CAR T-cell infusion, and it correlated very closely with the CAR T-cell expansion. It's important to share with you the information that in terms of fever, the patient treated for neuroblastoma had an even higher hyperpyrexia in comparison to children treated for B-cell precursor ALL. And as I mentioned during my talk, we needed to infuse the dimerizing agent in a couple of patients who develop a grade 4 CRS, not easily manageable with corticosteroids and tocilizumab. For this reason, we decided to infuse the dimerizing agent, and this treatment resulted into a rapid disappearance of clinical signs and symptoms of CRS.
Okay, thank you very much.
I asked something on a different level. I was very much wondering if the patients relapse under or after CAR T, it could be due to that at one point the CAR Ts are not there anymore, but sometimes also tumors like in hemato-oncology, they change in their pattern. Do you see, for example, any change in GD2 expression after giving CAR Ts? Is it also like being CD19 negative in B-cell leukemia, for example?
That's a terrific question, and thank you for raising it. Indeed, and those patients who relapse, the emergence of GD2 negative elements was a rare event. Indeed, we observed it only in 2 patients. So probably the more likely explanation is that the CAR T cells lost efficacy because of some immune suppressive depotentiating effect displayed by the tumor cells or by the tumor microenvironment. And as I mentioned a few seconds ago, the presence of a high proportion of myeloid-derived suppressor cells predicted a poorer expansion of the CAR T cell elements and also shorter persistence over time.
Thank you very much for your answer. May I continue, Paolo, for another one?
Yes, of course.
Is that I was much wondering because solid tumors express different things and also have, we know there are elements which express differentiating. Would you foresee a future where you would combine certain CAR Ts against GD2 and, for example, B7-RH3?
That's a good point. Indeed, we are thinking to prepare a CAR construct allowing the simultaneous targeting of both antigens. And another strategy could be that of including in the same CAR construct the SCB for the antigen of interest together with another part specifically addressing the tumor microenvironment, and in particular FAP could be a good alternative to be targeted together with GD2, exactly for the reason of simultaneously attacking both the tumor elements and the microenvironment, supporting the growth and the progression of the tumor cells.
Thank you very much. And I'm on the roll, but in the patients with the osteosarcoma you showed, I think it's quite impressive to see such a good response. How much GD2 expression would you consider enough to include such a patient for CAR-T? Or was there any specific level of expression or any level of expression?
For neuroblastoma, we didn't establish any threshold. For the bone sarcoma, we required that at least 1/3 of the tumor cell express GD2 for being eligible to be treated. And you have certainly appreciated from the slide that I presented that the clinical response that can be obtained through the use of GD2 specific CAR T cells in both Ewing and osteosarcoma is really impressive. So in principle, these bone tumors can become another type of neoplasia suitable to be treated with the GD2 specific CAR T cells. But what I like to particularly emphasize is that now, in view of these results, it's important to have the courage, let me use this term, to anticipate the use of CAR T cells in newly diagnosed patients, because the safety profile has been demonstrated that none of the patients we treated experience a fatal event related to toxicity, and considering the good safety profile and the results that were better in patients with a low tumor burden, my personal view is that of anticipating the use of CAR T cells in earlier phase of the disease.
Thank you very much. And one, I think, last question. How long will you think, if this continues succeeding, this will be available for a bigger trial or multi-center trial?
So we are closing, that's a very important question, and thank you for asking. We are closing now our mono-institutional trial, and we want to continue now to launch a multi-center trial, and we will be more than happy to collaborate with any institution potentially interested to work with us to further validate the approach on a larger cohort of patients, and also in children with much less advanced disease. Thank you.
Thank you very much.
Thank you very much for your talk and your discussion.
Thank you.
Thank you.
It was a great pleasure to interact with both of you. Thank you.
Thank you, Professor Locatelli, and thank you, Dr. Perez Albert and Dr. Van Evik. Ladies and gentlemen, the session has now concluded. If interested in CME accreditation, participants should fill in the evaluation form and pass the CME multiple choice test. To enter the CME section of the site, please close this window and go back to the ESO website. If you are a mastermind competitor, you will enter the quiz after the evaluation. The next ESO session will take place on the 17th of September at the same time. And Professor Gregory Kaltsas of the National and Kapodistrian University, Athens, Greece, will discuss with Professor Ashley Grossman of the Annette Centre of Excellence, Royal Free Hospital, London, United Kingdom. The following topic: neuroendocrine tumours, hereditary syndromes. Thank you for participating, and have a pleasant evening, day, or night. Goodbye.